All right. So a very good evening, everyone. I welcome you all to this particular YouTube session on clinical based questions in general medicine. Yes, so just please give me a thumbs up or text me yes if I am audible to everyone. Very good. So now let us start with today's discussion. So before starting the session, let me tell you that these clinical based questions, whatever I'm discussing every day on the platform of Arise Medical Academy, are very, very important. Please don't miss these questions or please don't miss these sessions at all. These are the sessions which will be giving you an edge in your upcoming FMGE exam. So without fail, please listen to this entire sessions. So in the today's session, I will be discussing clinical based questions on connective tissue disorders, right? And as well as we will take up one ECG and we will take up some questions on arterial blood gas analysis. All right. Okay. So let us start with the session. Okay. The first question is, we have a 20-year-old woman presents with bilateral conductive deafness, palpable purpura on the legs and hemoptysis. Radiograph of the chest shows thin-walled cavity in the left lower zone. Investigation reveal total leukocyte count 12,000 per cubic millimeter and red cell cast in the urine and serum creatinine 3 mg per deciliter. What is the most probable diagnosis? Henoch-Schonlein's purpura, Polyarteritis nodosa, Wegner's granulomatosis, disseminated tuberculosis. Yes, so anyone want to make a guess of these particular questions? Yeah, anyone? So 20 years women, what are the positive points? Bilateral conductive deafness, palpable purpura on the legs, and radiograph is showing the presence of a thin-walled cavity, and investigations reveal the total leukocyte count of 12,000 per cubic millimeter and creatinine is 3 milligrams per deciliter. So now you see what are the important structures which are affected. Okay, so we are getting the different answers now. But anyways, so the correct answer answered by Meghana Gaud and as well as Lakshmi. So Meghana Gaud and as well as Lakshmi, both of you have answered it correctly, right? Good. So now let me take up the discussion. The answer is Wegner's granulomatosis. Now, why is it Wegner's granulomatosis? Let me discuss. In case of Wegner's granulomatosis, it is the condition which is characterized by a triad, right? Now, what is this particular triad in case of Wegner's granulomatosis is, it includes the involvement of upper respiratory tract, it involves the involvement of lower respiratory tract, and there will be also involvement of the kidney. Right, involvement of upper respiratory tract, involvement of lower respiratory tract, and involvement of the kidney. So these are the triad of manifestations like what you will have in case of Wegner's granulomatosis. What is upper respiratory tract involvement given in the question? Conductive deafness, right? Conductive deafness. So your upper respiratory tract, it includes the nose, right? And even the presence of the conductive deafness, we can take into consideration as the upper respiratory tract involvement. Next, followed by that, you take the radiograph. The radiograph, it is showing the presence of thin-walled cavity. That means there is lower respiratory tract involvement as well. Then, followed by that, the kidney involvement. So how is the kidney involvement given in the question? In the form of serum creatinine 3 milligrams per deciliter. So These three are the classical manifestations what you will see in case of Wegner's granulomatosis. Now, many of you were thinking as Henoch-Schonlein's purpura, because the question says that there is palpable purpura on the legs and as well as the hemoptysis. Many of you were thinking that Henoch-Schonlein's purpura. Let me tell you, in case of Henoch-Schonlein's purpura, along with palpable, there will be palpable purpura, right, in Henoch-Schonlein's purpura. But conductive deafness is not the feature of your Henoch-Schonlein's purpura. And as well as the renal involvement is less likely in patients with the Henoch-Schonlein's purpura. Okay, so that is the reason why Henoch-Schonlein's purpura is not the answer. And in polyarteritis nodosa, how can we rule out this? Polyarteritis nodosa, I have a clinical question which is upcoming in the further part of the questions. There I will tell you what exactly will be the features of your polyarteritis nodosa, right? And it is not your disseminated tuberculosis, because in case of disseminated tuberculosis, what you will have the radiographic appearances, you will have mottled appearance in the chest x-ray in the disseminated tuberculosis. Okay, so now because you have a triad in this patient, that is, and what that to what triad? Upper respiratory tract, lower respiratory tract, and kidney involvement. That is classically seen in case of Wegner's granulomatosis. Now, can anyone tell me Wegner's granulomatosis, what type of vasculitis is this? Yes, can anyone tell me what type of vasculitis is your Wegner's granulomatosis? Right. So please tell me what type of vasculitis is your Wegner's, and please tell me what are the antibodies like what you will have in case of Wegner's granulomatosis. Please answer these two questions. What are the antibodies in Wegner's? And the second important thing, like what type of vasculitis is this? Very good, Lakshmi. It is your small vessel vasculitis, right? It is an example of small vessel vasculitis. Okay, now what are the other examples of small vessel vasculitis? Your Church-Strauss syndrome is a small vessel vasculitis, right? And your Henoch-Schonlein's purpura is a small vessel vasculitis. And the one what we are discussing now, that is Wegner's granulomatosis, is also a small vessel vasculitis. Then followed by that MPA, microscopic polyangiitis, is also a small vessel vasculitis. Now, in case of Wegner's granulomatosis, please tell me what is the antibody that will be positive. Yes, please tell me what will be the antibody that will be positive in Wegner's granulomatosis. Any one of you? So the antibody that will be positive in case of the Wegner's granulomatosis is C-ANCA. Right, C-ANCA is positive in case of Wegner's granulomatosis. Okay, so that is about the clinical question related to your Wegner's. And very important point is that why it is not polyarteritis nodosa. Let me tell you one of the very important point regarding polyarteritis nodosa. In polyarteritis nodosa, there is no lung involvement. Right, there is no lung involvement in case of the polyarteritis nodosa. So that is the reason why your polyarteritis nodosa is ruled out. Next, followed by that, we will see the next question. Okay, now I said you that in case of Wegner's, like you have three classical manifestations, right? What are those? Upper respiratory, lower respiratory, and kidney involvement. And among all these, first suppose if the question is asked, vasculitis is very common in which structure? Remember, vasculitis, it is more common in the upper respiratory tract. Right, vasculitis, it is more common in the upper respiratory tract. That is a very important point that you need to remember. Followed by that, second most common is lower respiratory tract involvement, and the third most common will be the kidney involvement. right? Third most common will be the kidney involvement. So these 3 points are very, very important. Okay, right. Next. Now you see the next important question. We have a 50-year-old man came to the emergency department with complaining of unilateral headache, diplopia, and difficulty in chewing the food as well. On evaluation, MRI was normal and ESR was persistently high. What is the most appropriate drug for treatment? Aspirin, Coxeps, prednisolone, sodium valproate. What do you think is the most appropriate drug for the treatment? Right. So first of all, you tell me what is the diagnosis. Right. First of all, you tell me what is the diagnosis, and then you tell me what is the drug for the treatment. Any one of you who will be the first person to tell me what is the diagnosis? Yes, VS, what is the diagnosis? Yes, can anyone tell me what is the diagnosis first? Okay, so you take the positive points. 50-year male complaining of unilateral headache. Very good. So VS has cracked the diagnosis, diplopia and difficulty in chewing the food. Yes, VS, can you tell me why there will be difficulty in chewing the food? Yes, Monica Swami, very good. Please tell me why there will be difficulty in chewing the food. The diagnosis is temporal arteritis. And the other name of your temporal arteritis is, this is also called as the giant cell arteritis. Right, this is also called as the giant cell arteritis, or it is also called as temporal arteritis. All right, now what is the point in favor of your temporal arteritis? Unilateral headache, right? And that too in the temporal area, right? That too in the temporal area in a patient aged more than 50 years. Right, in a patient aged more than 50 years. So that is what is suggestive of your temporal arteritis. That is what is suggestive of your temporal arteritis. So in temporal arteritis, what is the drug of choice? It is your prednisolone. It is your prednisolone. But I did not get the answer until now why there is difficulty in chewing the food. Any one of you, please? Why do they have, a patient with the temporal arteritis will have difficulty in chewing the food? Yes, Monica Swami. Very good, Balaraman. So this patient has difficulty in chewing the food because of jaw claudication, right? Because of jaw claudication. Okay, and why is this particular jaw claudication? If you take your temporal artery, it also supplies the muscles of the mastication. So when the temporal artery is inflamed, the supply to the muscles of mastication will be reduced, right? Supply to the muscles of mastication will be reduced. So when the supply to the muscles of the mastication is reduced, then obviously they will have the jaw tenderness, like they will have difficulty in chewing the food, right? They will have difficulty in chewing the food. Okay. Now, what is the most feared complication? Right? What is the most feared complication in these patients with the giant cell arteritis is sudden loss of vision. There will be sudden loss of vision, right? There will be complete blindness. And why is that? That is due to the involvement of the ophthalmic artery. That is due to the involvement of the ophthalmic artery. Next, the other important point regarding the giant cell arteritis that you should know is in 40% of individuals, right? In 40% of individuals, they will have Yeah, so they will have stiffness of shoulder and hip girdle, right? They will have stiffness of the shoulder and as well as the hip girdle. Okay, so that will be seen in almost like 40% of patients. And in case of giant cell arteritis, what is the drug of choice? That is your steroids, right? That is your steroids. Okay, so this completes a discussion on the very important topic, that is giant cell arteritis. I will summarize giant cell arteritis in just 2 minutes. Giant cell arteritis is a large vessel vasculitis. Giant cell arteritis is commonly seen in age group more than 50 years. Giant cell arteritis most commonly present with the unilateral headache, and they will have tenderness over the temporal artery because the temporal artery is inflamed. You can feel for the temporal artery in individual with the temporal arteritis. And the other name for the temporal arteritis is your giant cell arteritis. And the most feared complication is complete loss of vision due to the involvement of the ophthalmic artery. And they will also have jaw claudication. And in 40% of individuals, there will be stiffness of the shoulder and as well as the hip girdle. And in patients with the giant cell arteritis, you will see that ESR is elevated, right? Erythrocyte sedimentation rate is very high. Why? Because it's an inflammatory arteritis. And what is the drug of choice? You should give an anti-inflammatory drug. And what is that anti-inflammatory drug you have to give? Prednisolone. Right? What is the anti-inflammatory drug you have to give? That is prednisolone should be given. Okay. So this completes the question on the giant cell arteritis. Now, we will move on to the next question. Yes. Now, this is another very interesting question, and let me see how many of you can crack this. We have a 30-year-old male represents with numbness of both the lower limbs, right? Numbness of both the lower limbs and right upper limb. Examination reveals pulse rate of 88 per minute and blood pressure of 160 by 110 millimeters of mercury. He also has digital gangrene involving right second and as well as the third finger. Urine routine examination is unremarkable. Microscopic examination shows RBC, hemogram and serum biochemistry is within the normal limits. What is the most probable diagnosis in this patient? Systemic lupus erythematosis, polyarteritis nodosa, malignant hypertension, Church-Strauss syndrome. So you say that you take the positive points. 30-year-old male, that is the first thing. He is having numbness in both lower limbs and right upper limb. Blood pressure is 160 by 110. There is also digital gangrene of right second and third fingers. And microscopic examination of the urine shows RBC. Hemogram and serum biochemistry normal. What is the most probable diagnosis? Very good. So, right, very good, Lakshmi and as well as Arya Ajesh. So the answer to this question is nice, very good. So very happy that all of you are answering it correctly. So it is a case of the polyarteritis nodosa, right? It is a case of polyarteritis nodosa. Now, why is it the polyarteritis nodosa, right? What are the points in favor of your polyarteritis nodosa? So first of all, let me tell you that polyarteritis nodosa, it is a medium vessel vasculitis. Right, it is a medium vessel vasculitis. Okay, and this medium vessel vasculitis, that is polyarteritis nodosa. Remember, what are the other types of medium vessel vasculitis? What are the other examples? The other examples are TAO, that is thromboangiitis obliterans, right? Thromboangiitis obliterans. Next, the other one, what we have for your medium vessel vasculitis is Kawasaki disease. So these are the examples of the medium vessel vasculitis. Now, in case of polyarteritis nodosa, let me tell you one of the very important point, that lung involvement will not be there. In my previous question, I have shown you lung involvement was there in that question, whatever I have given you regarding the Wegner's granulomatosis. Remember, in polyarteritis nodosa, lung involvement will never be there. Remember that. Next, what are the points in favor of your polyarteritis nodosa? The points in favor of your polyarteritis nodosa include the presence of the digital gangrene, hypertension along with normal renal function, peripheral neuropathy. See, this is a very important point. Peripheral neuropathy is a very important point, right? And microscopic hematuria. These features, they will confirm the diagnosis of the polyarteritis nodosa. So polyarteritis nodosa is what? It's a medium vessel vasculitis. Now, the point is, we have another question here, that is the Church-Strauss syndrome. Now, how do you rule out this particular Church-Strauss syndrome? Now, I think I have said you in my previous question, that is Church-Strauss syndrome, it is a small vessel vasculitis. Right, Church-Strauss syndrome, it is a small vessel vasculitis. All right. Now, let me take up the points in favor of your Church-Strauss syndrome. See, the points in favor of your Church-Strauss syndrome is, there are totally 6 features in the Church-Strauss syndrome. Right, there are totally 6 features in the Church-Strauss syndrome. Out of these 6, if 4 are present, right, out of these 6 criteria, if 4 are present, then we call it as the Church-Strauss syndrome. Right, out of the 6, if 4 are there, it is Church-Strauss syndrome. Now, what are those 6 criteria of your Church-Strauss syndrome according to American College of Rheumatology? That includes asthma, eosinophilia, mononeuropathy or polyneuropathy. Whereas in case of polyarteritis nodosa, it is mainly mononeuritis multiplex, peripheral neuropathy will be there. Pulmonary infiltrates. And in polyarteritis nodosa, pulmonary infiltrates will never be there. Lung involvement is not at all there in case of polyarteritis nodosa. Next, paranasal sinus abnormality and extravascular eosinophils. So always remember, Church-Strauss syndrome, asthma and eosinophil count being elevated will definitely be there in your clinical question if the question is asked related to your Church-Strauss syndrome. Right? So these are the 6 features according to your American College of Rheumatology. And out of these particular 6 features, 4 features should definitely be there. Right? 4 features should definitely be there. Okay? Right. So that is about the Church-Strauss syndrome. Right? And so in this clinical question, what is the answer now? In this clinical question, the answer is the polyarteritis nodosa. All right? Next. Yes. Now, this is another very important question. And let me see how many of you can answer this. We have a 24-year-old female presents with abdominal pain, hematuria, and arthralgia. And on examination, palpable purpuric rash was seen on the trunk, limbs, and as well as over the buttocks. Coagulation tests were normal. What is the most probable diagnosis in this patient? Hemolytic uremic syndrome, Henoch-Schonlein's purpura, meningococcemia, thrombotic thrombocytopenic purpura. Right. So the clinical diagnosis, very good. So the clinical diagnosis in this case is a Henoch-Schonlein's purpura. Now, Henoch-Schonlein's purpura, remember, it is a small vessel vasculitis. Right? It's a small vessel vasculitis. And the points that you need to know regarding the Henoch-Schonlein's purpura is that in Henoch-Schonlein's purpura, it is characterized by a tetrad of manifestations. Right? It is characterized by a tetrad of manifestations. What is the tetrad? So please remember H, please remember S, Please remember P, HSP. What is this H stands for? Hematuria. What is this S stands for? Involvement of the skin. And that skin involvement will be in the form of rash. Right? Skin involvement will be in the form of rash. You take the P. The word P, it is your pain. So where do you have the pain? Pain in the joints. Right? Pain in the joints and as well as pain in the abdomen. Right? Pain in the joints and as well as the pain in the abdomen. Okay, so these four manifestations are seen in case of Henoch-Schonlein's purpura. Hematuria, skin rash. Now, what is this skin rash? This skin rash, it is in the form of palpable purpura. Right? This skin rash, it is in the form of palpable purpura. Now, why is this palpable purpura present? Remember, palpable purpura, whatever is present in case of Henoch-Schonlein's purpura, is not because of thrombocytopenia. The palpable purpura, whatever is present in patients with the Henoch-Schonlein's purpura, is due to vasculitis of the cutaneous blood vessels. Right? It is due to vasculitis of the cutaneous blood vessels. Okay, so that is what is your palpable purpura due to, but it is not due to thrombocytopenia. And this palpable purpura in case of the Henoch-Schonlein's purpura, it is more distributed over the trunk, it is more distributed over the limbs, and it is more distributed over the buttocks. Right? So the purpura is more distributed over the trunk, limbs, and as well as the buttocks. So please remember this very important point. Okay. Now, what are the other manifestations of your Henoch-Schonlein's purpura? Now you take these. Yes. Yeah. Now what is the age group at which you will see Henoch-Schonlein's purpura? Remember, Henoch-Schonlein's purpura is most commonly seen in, right? It is most commonly seen in children. Right? Most commonly seen in children. Okay. Yes, surgeon with passion. Good evening, Satish. Okay. So it is more commonly seen in children and young adults. Right? And young adults. And if you take the ANCA is negative in patients with the Henoch-Schonlein's purpura. Right? ANCA is negative in case of Henoch-Schonlein's purpura. And the antibodies accumulated in the immune complexes are IgA antibodies. And if you take the serum IgA levels, they are elevated. Right? The serum IgA levels, they are elevated. Okay. And you take the ESR in patients with the Henoch-Schonlein's purpura. ESR in patients with the Henoch-Schonlein's purpura is elevated. And regarding the platelets, already I have said you, platelets, they are not reduced in case of Henoch-Schonlein's purpura. Remember, the platelets, they remain normal. They will not have thrombocytopenia. Right? They will remain normal. WBCs, there will be mild leukocytosis. Right? WBCs, there will be mild leukocytosis. And if you take the urine analysis will show the presence of the RBC. And there can be even mild proteinuria as well. Right? There can be even mild proteinuria as well. And if you take the serum complement levels, in spite of immune complexes depositing within the glomeruli, the serum complement levels, they remain normal. Right? The serum complement levels, they remain normal. Okay. So that is what you will see in case of Henoch-Schonlein's purpura. So age of the individual, most commonly seen in children rather than young individuals. ANCA negative. IgA antibody levels in the immune complex are elevated. Serum IgA levels elevated. ESR will be elevated, but the platelet count will be normal. And there will be mild leukocytosis. Urine analysis will show RBC and proteinuria. And serum complement levels will be absolutely normal in spite of the immune complex deposition. Next. Now tell me, what is the drug of choice for Henoch-Schonlein's purpura? Yes. What is the drug of choice for Henoch-Schonlein's purpura? Yes, can anyone tell me? What is the drug of choice for Henoch-Schonlein's purpura? Drug of choice for Henoch-Schonlein's purpura is, yes, any one of you please? No. Drug of choice is steroids. Right, drug of choice is steroids. Yes, Tenso, not IVIG. Okay, yes, Getsuga's Tenso, because you have come up with a point of IVIG, that is intravenous immunoglobulin. Yes, Tenso, can you tell me IVIG, intravenous immunoglobulin, are given in which type of vasculitis? Can anyone answer this? In which type of vasculitis you will give intravenous immunoglobulins? In which type of vasculitis you will give intravenous immunoglobulins? Yes, Tenso, can you tell me, or any other student? Right. So if you take this IVIG, it is given in case of Kawasaki disease. Right, in case of Kawasaki disease, we give this particular IVIG, intravenous immunoglobulin. All right, next. And what is Kawasaki? Kawasaki, it is a medium vessel vasculitis. Right, it is a medium vessel vasculitis. Right, very good, Tenso. So it is given in case of Kawasaki. And Kawasaki, it is a vasculitis which is commonly seen in children. Right, Kawasaki, it is commonly seen in children. Okay, right. So that completes the clinical question on the Henoch-Schonlein's purpura. Next. Now, see, this is your palpable purpura. Now, where is this palpable purpura distributed in case of this Henoch-Schonlein's purpura? This is distributed over the lower limbs and as well as over the buttocks. And not only that, the purpura, they are also distributed over the trunk. Right, they are also distributed over the trunk. Right, next. Yes, one question on the ECG. Right, one question on the ECG. Right, so if I am not wrong, definitely you will be getting one question on the ECG in your upcoming FMGE exam without fail. Okay, so please be prepared for that. So we have a 18-year-old boy is brought to your hospital with loss of consciousness. He regains consciousness in the emergency department and GCS on admission is 12/15. CNS examination is normal and auscultation reveals a narrow split S2 and clear lungs. ECG was done. So what do you think is the diagnosis in this patient? Left outflow tract obstruction, right outflow tract obstruction, atrial fibrillation with cerebral embolism, subarachnoid hemorrhage with T-wave inversions. "18-year-old boy presented with loss of consciousness to the emergency department. GCS is 12/15. CNS examination is normal. Auscultation shows a narrow split S2. ECG was done. ECG is this. Yes, Gopalakrishnan, subarachnoid hemorrhage. Okay. No, it is not subarachnoid hemorrhage. So in subarachnoid hemorrhage, do you think that you will have that narrow split S2? Yes, Gopalakrishnan, do you have narrow split S2 in subarachnoid hemorrhage? Right outflow tract obstruction. Okay, right. See, the patient is having loss of consciousness. This is a very, very important history, right? This is a very, very important history, loss of consciousness. Right, very good. So the correct answer has come from Monica 7777. Yes, Monica. The answer is left ventricular outflow tract obstruction. Yes, Monica, can you tell me what is that left ventricular outflow tract obstruction which made the 18-year-old boy into a state of loss of consciousness? What is that left outflow tract obstruction? Can you tell me, Monica? Right. So if you take the ECG, what is there in the ECG? ECG, it is suggestive of left ventricular hypertrophy. ECG, it is suggestive of left ventricular hypertrophy. Okay, now let me tell you what is that left outflow tract obstruction. The left outflow tract obstruction here is aortic stenosis, right? Aortic stenosis. So now in aortic stenosis, what is the cause of aortic stenosis? Sir, how are you saying that it is aortic stenosis? Now in 18-year-old boy, what I suspect to the cause of the aortic stenosis is congenital aortic stenosis. Right? Congenital aortic stenosis. And what is that congenital aortic stenosis? That is bicuspid aortic valve. Right? Bicuspid aortic valve. So it is the bicuspid aortic valve. Right? It is the right. So it is your bicuspid aortic valve which is responsible for the aortic stenosis in this patient. Bicuspid aortic valve. Okay. Right. Now, in case of aortic stenosis, you will have this narrow split S2. Right? Narrow split S2. Now the question is why? Because in aortic stenosis, there will be delayed A2. Right? There will be delayed A2. Now because there is delayed A2, so you have A2 and P2. So if your A2 is delayed, what will happen? The split will become narrow. Right? The split will become narrow. Okay, just 1 minute. Okay, so the split will become narrow if A2 it moves near to your P2. So now why, sir, why are you telling left ventricular hypertrophy in this patient? Why? Because you take your V5 and as well as V6. V5 and V6, there is large amplitude QRS complex. Right, there is large amplitude QRS complex, and along with that in V5 and V6 there is also T wave inversions. Right, there is also T wave inversions. So that is the reason why I am calling it as left ventricular hypertrophy. Now the other important point that you should know here is there is a criteria to call it as left ventricular hypertrophy. There is a criteria. Now what is a criteria? The name of the criteria is Sokolov-Lyon criteria. Right, the name of the criteria is Sokolov-Lyon criteria. Right, now what is your Sokolov-Lyon criteria? What is your Sokolov-Lyon criteria? What is your Sokolov-Lyon criteria is, that is SV1 plus RV6 it should be more than 35 mm. Right, SV1 plus RV6, it should be more than 35 mm. Right, it should be more than 35 mm. That is what is called as Sokolov-Lyon criteria. SV1 plus RV6. What do you mean by the word SV1? See, this is your S wave in V1 and this is your R wave in V6. So if you add both of them, if the amplitude is more than 35 mm, this we call it as left ventricular hypertrophy. Okay, so that was satisfied. The criteria was there in my previous ECG, whatever I was showing to you. Now, what was the second option? Second option is right outflow tract obstruction. Now, one of the example of your right outflow tract obstruction is your pulmonary stenosis. Right, one of the example for right outflow tract obstruction will be pulmonary stenosis. And in pulmonary stenosis, what is that you will have? You will have right ventricular hypertrophy. Right, in pulmonary stenosis, what you will have is you will have right ventricular hypertrophy. Now, what is the criteria for right ventricular hypertrophy? In right ventricular hypertrophy, you will have a dominant R wave in V1. Right, you will have a dominant R wave in V1. And along with that, there will be also T wave inversions in your right-sided leads. Right, there is also T wave inversions in right-sided leads. Okay, so this is the story of your pulmonary stenosis. So there is right ventricular outflow tract obstruction, there will be right ventricular hypertrophy. In left ventricular outflow tract obstruction, there is left ventricular hypertrophy. And you take this loss of consciousness. Loss of consciousness, it is most commonly seen in case of left outflow tract obstruction. And what is the cause of this left outflow tract obstruction in this patient? That is aortic stenosis. And what is the cause for the aortic stenosis in an 18-year-old boy? That is congenital aortic stenosis, which is nothing but bicuspid aortic valve. Which is nothing but your bicuspid aortic valve. Now, and some of you were answering it as D. Some of you were answering it as D. That is subarachnoid hemorrhage with T wave inversions. Some of you were answering it as subarachnoid hemorrhage with T wave inversions. Now let me tell you, in case of T wave inversions of subarachnoid hemorrhage, in case of subarachnoid hemorrhage, there will be raised intracranial pressure. And because of this raised intracranial pressure, you will have T wave inversions in all the leads. I will show you that ECG. Right, you will have T wave inversions in all the leads. Okay, you see this. Right, so this is nothing but your T wave inversions, deep T wave inversions. So you can make out these T wave inversions, they are almost present in all the leads in case of the subarachnoid hemorrhage. Except in your AVR, except in your AVR, because AVR, everything will be reverse. Every time and all time, it will be reverse. In other leads, if there is upright T wave, you will have T wave inversions in the AVR. In other leads, if you have T wave inversions, you will have upright T wave in AVR, right? So it is always reverse, okay? So this is the ECG of subarachnoid hemorrhage with T wave inversions. Right, next. Now, so to summarize this, what is the diagnosis? The diagnosis is left outflow tract obstruction. And what is the cause? Aortic stenosis. What is the cause of aortic stenosis? That is your bicuspid aortic valve. Why are you telling it is aortic stenosis? Because there is narrow split S2. Because there is narrow split S2. Okay, right. Now, sorry, I did not keep the image for this. Huh? Okay, just 1 minute. Yes. Answer this question. Allen's test is used to assess. Yes, Vassal, good evening. Allen's test is used to assess the integrity of. Yes, Irfan, good evening. Radial artery, ulnar artery, palmar arch, brachial artery. Yes, please answer this question. Allen's test is used to assess the integrity of. Right. So I did not get the correct answer from any one of you. Allen's test, it is used to assess the integrity of the palmar arch. Okay. Only Getsuga Tenso has answered. Only Tenso. The answer is the palmar arch. Okay. So Allen's test is used to assess the integrity of the palmar arch. Now, what is this Allen's test? How do we do this particular Allen's test? Let me tell you. So Allen's test is the test which is done before performing ABG, right? Before puncturing your radial artery, right? Before puncturing your radial artery for arterial blood gas analysis, we do this particular Allen's test, right? We do this particular Allen's test. Okay. Now, let me tell you what is this Allen's test and how do we do. Now, what we have to do is we have to apply the pressure on both ulnar artery and as well as the radial artery. Both the vessels are occluded. When both the vessels are occluded, what will happen? The blood supply to your palm, right? Blood supply to the palm is reduced, right? So how will be the palm? How does the palm appears? The palm, it appears completely pale, right? The palm, it completely appears pale. I'll show you that. Now you see this. Okay, so he has occluded both ulnar artery and as well as the radial artery. So when both radial and as well as ulnar artery has been blocked, you see this, the palm, it has become completely pale. Now, subsequently what you have to do is, just 1 minute, I'm very sorry. Reduced. Right. So now subsequently what you have to do is you release one vessel, right? So here, which vessel he has released? He has released the radial artery. Once he has released the radial artery, the entire palm has become red, right? The entire palm has become red. Okay, so the entire palm has become red. Now, why do you think that the entire palm has become red when the radial artery is being released? That is because of the palmar arch is patent. What is the palmar arch? It is the palmar arch is the one which will connect your radial artery and as well as the ulnar artery. So ulnar artery, it supplies the medial aspect of the arm. And radial artery, it supplies the lateral aspect of the arm. But if any of this vessel is blocked, like for example, radial artery is gone, no problem, we need not worry. Why we need not worry? Because we have the ulnar artery connected to the palmar arch and it will supply to the lateral side also. So the integrity of the palmar arch is very important before doing the before doing the ABG, arterial blood gas analysis. Now in arterial blood gas analysis, what you will do, you will puncture the radial artery. You will puncture the radial artery. When you puncture the radial artery, what happens? The radial artery can go into a state of vasospasm. Right? Radial artery can go into a state of vasospasm. So once the radial artery goes into a state of vasospasm, now if your palmar arch is patent, then ulnar artery will supply the blood to the lateral aspect of the hand as well. Right? Ulnar artery will supply the blood to the lateral aspect of the arm as well. Why? Because radial artery has gone into a vasospasm when you have done your arterial blood gas analysis. Okay, that is what is called as the Allen's test. So before doing arterial blood gas analysis, please remember you have to do Allen's test. Without doing this Allen's test, please don't perform your ABG. This is a practical point, right? This is a practical point. Yes, just give me a thumbs up or text S if you have understood this Allen's test. Yes, tell me whether you have understood this Allen's test or not. Okay, very good. Now, so what is the take-home message? The take-home message is that Allen's test is used to assess the integrity of the palmar arch, right? Next. Now, we will move on to the next question. Yes, this is the question related to your ABG, right? So, yes, I don't know how many of you have attended the yesterday's ABG class. So, in the yesterday clinical based discussion, I have discussed all the questions related to your arterial blood gas analysis, right? All the questions were arterial blood gas analysis in the yesterday's session. If anyone has missed the yesterday's session, please watch that yesterday's session as well. Because in the yesterday's session, I have taken up the discussion of the clinical based questions. So on arterial blood gas analysis, right? Please watch that. And let me see how many of you can answer this question as well. So 60-year male with amyotrophic lateral sclerosis is brought to the clinic with history of somnolence, then normal. Also complaining of the morning headache and does not feel refreshed when he wakes up. The ABG is 7.37. Right, ABG is 7.37. Partial pressure of the carbon dioxide is 57. PO2 is 57. And bicarbonate is 34. What is the diagnosis? Right, so now let me crack this question for you all. So you take the pH of these individual. It is a normal pH. Right, it is a normal pH, okay? And you see the carbon dioxide. Carbon dioxide, it is elevated. So if carbon dioxide is elevated, what do we call that as? That is respiratory acidosis. Right? And bicarbonate is 34. So bicarbonate is increased. So when bicarbonate is increased, what does that tell you? That tells you metabolic alkalosis. Right? That tells you about the metabolic alkalosis. So now this patient has, right, this patient has respiratory acidosis and metabolic alkalosis, and the pH is completely normal. So when pH is completely normal, what did I tell you yesterday? When pH is normal, we call that as fully compensated, right? We call that as the fully compensated. Okay, now we have two options with fully compensated. What are those two options fully compensated? One is your option A and the other option is C. Now they will not have metabolic acidosis. What they have, the patient has metabolic alkalosis and respiratory acidosis. So what is the answer? The answer is fully compensated respiratory acidosis, right? Fully compensated respiratory acidosis. Okay, so if you want to understand these type of clinical based questions on ABG, please go back to my yesterday's session on YouTube. That is available to you in a recorded format under Arise Medical Academy YouTube channel, and you can watch the yesterday's ABGs. So if I'm not wrong, I've discussed 7 to 8 ABGs with clinical based scenarios, right? And this is one type of it, right? Now, okay, so many of you are answering A. Yes, Sai Taruni, can you tell me, now this patient is having respiratory acidosis, right? Please tell me whether it is a chronic respiratory acidosis or whether it is an acute respiratory acidosis. Yes, please tell me whether it is chronic or whether it is acute respiratory acidosis. Yes. Now, how to crack this, right? How to crack whether it is an acute or chronic. See, first of all, based on the history itself, you can assess 60-year male with amyotrophic lateral sclerosis. Now, in case of amyotrophic lateral sclerosis, these individuals in long term, they will develop respiratory muscle weakness, right? They will develop respiratory muscle weakness. Okay, and because of respiratory muscle weakness, the individual is having respiratory acidosis. That is one thing we can come to a conclusion. And the other thing is that, right? The other thing is that now you take this word chronic. Why and when and how we call it as chronic? Let me tell you. See, for 10 millimeters of mercury rise in your carbon dioxide, how much should be the rise in bicarbonate? If it is chronic, there should be 4 times increase in your bicarbonate, right? There should be 4 times increase in your bicarbonate if you want to call it as chronic. Now you take the how much is your PCO2? 57. Like, okay, we will take what is the normal value of your PCO2? Normal value of your PCO2 is your 36 to 44. What we will do now? We will take the average value as 40, right? For easy calculation, we will take the average value as 40. Now, if you take from 40 to 57, okay, even this value also, we will round it off to 60. That means how much it has increased? It has increased almost like 20 millimeters of mercury, right? It has increased almost 20 millimeters of mercury. So for 10 millimeters of mercury increase, there should be increase in bicarbonate by 4 times. If there is 20 millimeters of increase in your carbon dioxide, let me tell you, the bicarbonate will become 8 times more, right? 8 times more. What is the normal bicarbonate value? The upper limit of your bicarbonate value is 26. Now to this particular 20, actually the bicarbonate is 22 to 26, right? Okay, in this patient, I will take 26 as a upper limit normal value. So if I add 8 to the 26, how much it becomes? 34. What is the patient bicarbonate? It is 34. Patient bicarbonate is 34. So now what type of respiratory acidosis is this? Chronic respiratory acidosis. Whereas you take in case of acute, sir, you did not tell us what will happen in acute. I will tell you. In case of acute, right? In case of acute, for 10 millimeters of mercury rise in your carbon dioxide levels, there will be increase in bicarbonate level by 1 time. in acute, bicarbonate increases by value 1 if there is increase in your carbon dioxide more than 10 millimeters of mercury. Whereas in chronic, if there is increase in your partial pressure of carbon dioxide more than 10 millimeters of mercury, then bicarbonate increases by 4 times, right? So that is the reason why the answer to this particular question is fully compensated chronic respiratory acidosis, right? It is your fully compensated chronic respiratory acidosis. Okay, so that will be the answer to this question. That will be the answer to this question, right? So with this, I will wind up the today's session, right? And tomorrow again at around 6:30, I will be there live in front of you to discuss many more clinical based questions. Please don't miss this clinical based sessions. I am saying you repeatedly, these clinical based sessions will give you a very important edge to solve from 149 to 150. Okay, so these sessions are very, very important. These are available to you in a recorded format. Please inform to your friends also to watch these sessions, and all of us, let us together see that you will definitely clear your FMGE exam, right? So thank you very much, and I'll be waiting for you all tomorrow at 6:30 to discuss many more clinical based questions. Thank you very much.